I'm honored to be able to talk about this subject that interests me so much. Uh, to my history, I might mention that I've done this for a long time. I have nothing to disclose regarding this, either with the companies involved or anything else. My personal history started in the mid-90s with when I started using mechanical disc prosthesis. At that time, it was Charité products that were available. As many of the followers, they were purely mechanical. They sure restored mobility, but not the counter forces to mobility, that is the capacity of the healthy disc. They just made a lax, loose mobility. When we consider what type of patients we do our surgery on, the patients have been suffering from a long-term low back pain. When pain starts, there is a reflective contraction in erector-spinal muscles. And after years of pain, they are extremely short and strong in these muscles, but not often in their abdominal counterforcing abdominal muscles. They also develop a fear of motion, keeping these muscles in their glutes and along the spine on tension at all time. That is how the patients are when they reach us. So if we put in a mechanical disc prosthesis, there's a risk that the very short and strong erector muscles will bring them into segmental hyperlordosis. On the case to the left, it's probably partly because the fusion that was done there was without any lordosis, but there was no counterforce in the mechanical disc, so they tilted over and destroyed their facets. It was early obvious that facet joint arthritis was frequent in after a couple of years of mechanical total disc replacement. We tried to avoid adjacent segment disease by restoring mobility, but then we had some patients that developed this instead. I started an extensive preoperative program to deal with these strong and shortened muscles and to strengthen their rectus abdominis muscles to reduce this. And they had to do this program for a full year after surgery. And the frequency of facet joint arthritis was largely reduced, but it was not eliminated. And it was very demanding for the patients. If they were not motivated, they wouldn't do it, and then they'd probably come back in a couple of years with problems with the facets. So I started to search whether there was a prosthesis that could help me with this. So it was not just the patient's training and exercise that sacrificed them. So I started with the LPSP, the SAC prosthesis, the viscoelastic one, almost 5 years ago. Theoretically and in practice, it would reduce risk of segmental hyperlordosis, and in that fashion, reduce the risk of facet problems. I did quite a series of that prosthesis, and the results were so promising, both in outcome and especially on the facets. So I started a randomized single-blind controlled trial with 250 patients. I'll tell you more about it. Before the study, I did a lot of cases, as I said, in a series, and the results reported from the patients were very satisfactory, both in treating the low back pain, but actually avoiding coming back later with facet joint problems. Just some examples from this series. As you see, I always place them all the way back to the PLL, really to distract or unload the facets. And also that is a very nice position for the prosthesis. You don't have to worry about migration or things like that. This is just different cases. I didn't done 1, 2, 3 level cases with this disc, not 4 level. Then it's been a hybrid. So the randomized controlled trial that I started was an equal randomization in each group between the 2 best mechanical prostheses. In my mind, the peak-on-peak orbit prosthesis and the best viscoelastic prosthesis that I could find, the LPSP, or as we call it, the SAC prosthesis. In the study, it had to be maximum 2 segments to treat, not more cranially than 3, 4. I divided the patients into 3 groups: 1 segment cases, 2 segment cases, and hybrids. That is also 2 segment cases with 1 total disc replacement and 1 ALIF. And they were, in each group, it was an equal randomization between the brands of disc prosthesis. All patients had the same pre- and post-operative program by the same physiotherapist and me. And that was a program that we developed when we just had the mechanical prosthesis. The implant was blinded for the patients until the 2-year follow-up. All patients are now treated. Last patient in March 20. That means that we have a lot of follow-up to do. The follow-up is done by questionnaires from the Swedish Spine Registry at 1, 2, 5, and 10 years. And then we register all spinal procedures in this registry, not only a study like this. I achieve X-rays with flexion extension at 1 and 2 years. And after 2 years, I do a 3D CT focused on facet joint stress and mobility. The first publication from this study will be on the 2-year results, so it has to be awaited some time. But what we've seen this far is that no patient in the viscoelastic prosthesis group had so far reported any facet-related problems, and no hyperlordosis have been seen on X-rays. And that corresponds to my first series before the randomized controlled trial. We have had reports of facet-related problem in the mechanical prosthesis group, and segmental hyperlordosis has been seen on X-rays. Not a bunch, but some. Very few patients, but there are like 2 or 3 patients that with mechanical prosthesis that have the quirking sound that they suffer from because even if it's not painful, it's annoying. And you can always think, is it the prosthesis or is it the facets that is making this sound? When using viscoelastic prosthesis, we gain something. We gain a counterforce on mobility that is more natural than a true mechanical prosthesis. But the stiffness of the implant is demanding on implant strength. You have to check bone density carefully if in doubt, because my impression is that this prosthesis is a little more challenging on bone, on end plate strength. You have to be very careful when you prepare the end plate so you don't induce any harm to them, and you have to see too that the implant is all the way to the PLL, as I mentioned, both for intended mobility and neutral load from the end plate of the implant and on the bony end plate. Thank you.